Hi guys, welcome back to our channel, Your Neighborhood Nurse. I hope you guys are all doing well. To our returning subscribers, thank you for coming back. To our new subscribers, you're welcome to join the family. Today we're going to be treating another section of the mental health nursing, which is mood disorder. Um, so we're going to be talking about bipolar and the related disorders. Okay. Bipolar is a disorder that is characterized by extreme changes in mood, energy, and ability to function. There are different classifications of bipolar. We have bipolar 1 disorder, bipolar 2 disorder, cyclotamic disorder, and mixed features. All right, guys, let's go ahead. So, what is the assessment? How do we assess this patient? We assess and monitor whether the patient is in danger of self or others. Remember, some of these patients would be feeling very depressive and they will be suicidal. So, it's important that you assess if the patient is a danger, not just to themselves, but to the other people around them. Okay, so assess for alcohol or substance use or misuse. You can also assess their mood, their behavior. How are they behaving? Are they overly active? If they're overly active, you will know that it will affect their day to day activities. That means their hygiene will suffer, their nutrition will suffer, even their sleep mood would suffer as a result of this. So, their speech, flights of ideas, tangential, cognitive functioning. Can they think properly? Can they carry out their day-to-day activities? Can they do their normal day-to-day routine even when they're having these episodes? Inflated self-regard, like delusion or grandiose. Do they feel that they're grandiose, they're somebody else? These things have different interventions for patients like this. Sleep patterns, impulse control. Are they impulsive? Now, uh so these we have some medications that are given to this patient. Some of these patients are given lithium carbonate. You monitor the serum lithium level to keep the medication in the therapeutic index. A stable intake of adequate sodium and fluid must be maintained to avoid lithium toxicity. When we get to the medication part, you will know the signs and symptoms of when patients are having lithium toxicity and what is expected of the nurse to do. Other medication may be prescribed, but to reduce symptoms of acute bipolar mania episodes and for maintenance therapy. Okay, anti-anxiety to the LAMs and the PARMs may be prescribed to assist in managing their psychomotor agitation characterized by mania. This medication should be avoided in clients with previous substance abuse so they don't get addicted. Okay, so what are the interventions of mania? What can we do? We remove hazardous objects from the environment. This should be done for the client to avoid them using it to injure themselves or others, or even others too. Assess the clients closely for fatigue because sometimes they are overly active, high energy, so they run themselves and they are too tired. And sometimes when they're running themselves, they've not had enough food, so they're too tired. Provide frequent rest period and monitor sleep patterns. We use comfort measures to promote sleep patterns. We use calm and slow interaction. Yes. Ignore or distract the patient from grandiose thinking. So some of these patients would show grandiose behavior, we can use other things to distract them or ignore their grandiose pattern and present them reality. So let's say, for example, the the patient says, "Oh, do you know I'm the CEO of this hospital?" You bring the patient gradually with therapeutic conversation and bring them to reality that they are actually clients in the hospital. Okay, do not argue, don't argue with the client. Provide high calorie finger food and fluid because they are always on the run. So you should provide them food that they can eat along, even when they are still overly active, just so they can have energy. Okay, reduce environmental stimuli so they can relax. Limit inappropriate behavior. Set limits on their behaviors, appropriate behaviors. avoid competitive gain, especially for patients that have grandiose. Okay, provide simple and direct explanations, something they can understand at the go, not complicated. Now, let's look at another mental health disorder, depression disorder. What is depression? Depression affects feeling, thoughts, and behavior and can occur after loss. After a patient or a client has experienced a loss, it can be loss of self-esteem, loss of a significant relationship or a loved one, or even a therapeutic event like rape, and so can cause depression. Okay, note, loss of loss is followed by grief or mourning when it's unresolved, and it can lead to depression. So when the patient cannot resolve, when they cannot move from grief to mourning, when they cannot leave that stage, the loss stage, the DADAP. Do you know DADAP? Okay, the loss stage, they it can lead to depression. So the patient would be feeling depressed. The patient will be feeling depressed. Okay. We have types of depression. We have mild depression. We have moderate depression. We have major depression disorder. Let's look at them one after the other, from mild, moderate, and major. So let's look at mild depression. Mild depression is triggered by external factors, external events following a normal grief. It occurs in less than 2 weeks. The patient will feel sad, they'll feel let down, they'll feel disappointed, mild alteration in sleep patterns, feeling less alert, irritable, disinterested in spending time with others, increase or decreased appetite, increased use of substance of like alcohol or drug. Now take note of the word mild, nothing excessive happening here, and it's less than 2 weeks. Let's look at moderate depression. This one persists over time. The person or the client experiences a sense of change and often seeks help. They're despondent and they are gloomy. They feel dejected. They have low self-esteem. They're helpless and they're powerless. They have intense anxiety and anger. The person or the client may feel better after a certain time of the day, and then boom, they are back to their gloominess. Okay, slow thought process and difficulty in concentration, persistent thinking about and discussing of a particular subject. Okay, negative thinking and suicidal thought. This is very important to take note of. Sleep disturbance, early morning awakening, oversleeping, social withdrawal, anorexia, weight loss or gain, and fatigue, moving or talking slowly. These are some of the signs that the patients will show that will make you know that this patient has gone from mild to moderate depression level. And let's look at major depressive disorder. This depressive this depressive mood, here the patient has less pressure and activity for at least 2 weeks, impaired social, occupation, and educational functioning. So they can't just do anything. The mood change from the person's baseline, daily experience of at least five of the following symptoms. So they daily experience at least five of these following symptoms I'm about to mention. So first is irritable, depressed mood most of the day, nearly every day. Okay. They have decreased interest or pleasure in most activities, things that usually excite them, things that usually make them, very things that are usually interested in, it no longer interests them. Significant weight change or change in appetite, change in activity level, usually to very low activity level. They don't want to do anything, they don't want to leave the bed. This is where they like close the windows, make everywhere dark. Fatigue or loss of energy, guilt, and worthlessness, diminished ability to think or concentrate, or they are more indecisive here too. Thoughts of death and suicide. Now, what are the things we can do for patients that are experiencing depression? First of all, we need to take note of their risk for harm. And once we know that they are at risk of harming themselves or the people around them, we would take note of the type of things that are around them, and how we safety measures for suicide and safety measures to prevent suicidal attempts. Okay, assess for homicide or suicidal ideation or ideas, provide safety from suicide actions. So be certain that there are no harmful objects around the environment that they can use, nothing they can use to kill themselves around. Don't leave the patient alone for an extended period of time. Yes, this patient needs regular check. If the client has suicidal plans, place them on one-on-one supervision. So these are patients that all of that stay close to the nursing station. Patient that needs one-on-one supervision. Form a non-suicide contract with clients as appropriate. So maybe the client will need to sign a contract that they are not going to attempt anything to kill themselves, and then in return they will be reinforced with something they want. Okay, provide activities, use gentle encouragement to participate in activities of daily living and unit therapies. Yes, it should be gentle, not forced, not compelled. Don't push decision making or making complex choices to the patient. Remember, they have low mood from their normal baseline, mood change from their normal baseline, and they don't want to do anything. So their nutrition is also important so they don't become anorexic or weight loss. Okay, monitor their intake and weight and provide nutritional support. Provide them with what they can eat. Stay with clients during meals to accurately assess their intake and to ensure they are getting the adequate nutritional intake required. Hygiene is also important because they have low mood and they have change in activity level, low activity level. It's important also that the nurse takes care of the client's hygiene. Okay, sleep patterns and altered thought process. Here, the nurse will use therapeutic conversation to keep encouraging and helping the patient. Now, we're done. We did mood disorder and we've talked about depression. We talked about mild depression, moderate depression, and major depressive disorder, and some interventions that we can do to help the patient. Now, in all of this, it's important to take note of suicide. And once you hear the word suicide, what you should be thinking about would be safety measures to prevent or prevent the patient from committing suicide. So in this topic, what you should remember for some NCLEX questions will be talking about safety. This is very important. This is where some of the questions for NCLEX will come from. Safety measures, safety precautions on how the patient can how the nursing intervention can prevent suicide or other things that the patient can do to kill suicide thoughts and suicide ideation or even suicidal actions. So safety is very important. Also, you need to take note of when the patient has gone to major depressive symptoms. Another question you can be asked in NCLEX would be about supervision. Where do you place clients with suicidal thoughts? Obviously, I just told you in intervention that this client requires one-on-one supervision. So that patient will be supervised. And when it's asked which room will you apportion to, of course, the patient that is suicidal will be a room very close to the nursing station where the nurse's eyes can be on the patient. Okay, with that said, let's look at ECT, electroconvulsive therapy. This is another thing that is used in mental health therapy. Okay, ECT is an effective treatment for depression, but it's not a cure of depression. Okay, as what happens during ECT, a small amount of electric current is delivered through electrodes attached to the temples that causes seizures within the brain. Outward movement is usually slight movement of hands and feet or toes. Before this, of course, the patient would have gotten a pre-medication to help them relax their muscles and short anesthetic medication as well. Now, what happens during ECT? The course of this ECT is administered within a course of 6 to 12 months. It's usually given 2 to 5 days. And then the patient would have a maintenance ECT once a month to reduce relapse rate. Okay. Now, ECT is not always effective in clients with dystamic depression or depressive personality disorder, or even social difficulties. Also, clients with risk of myocardial infarction, stroke, or intracranial masses too, they don't get ECT. Okay, so now let's look at uses for clients. Okay, so ECT is used for severe depressive and bipolar depressive disorder, especially for clients that has psychotic symptoms and features that are intense delusion of guilty, somatic delusion, and delusion of infidelity. This is where you use ECT. These categories of patients, okay? Depression marked with psychomotor retardation and stupor. Mania with lithium resistance. Remember, I talked about the medication when we talked about mood disorder, when we talked about hypomania and mania. Lithium is a drug administered to this patient. So when patient has mania with lithium resistance, we give ECT therapy to them. Also, schizophrenia patient, especially patient that has catatonia, okay, psychotic and schizophrenia syndrome. Now we're going to be looking at the pre-procedure, during and post-procedure of what we need to do during ECT. So first, we have to explain the procedure to the client. We encourage the client to discuss their feelings. What do they know about ECT? What are the myths they've heard about ECT, and how we can debunk this myth? So we can know how we can debunk this myth and teach them the appropriate information they need to be aware of. Also, we teach the client's family what to expect during ECT. Remember, when the electric current is administered, the client will have seizure, like they would shake their hands, their feet will shake. So the family will not think their family member is dying, and then it will be a problem. So you have to educate them as well. Informed consent from the client if the client has informed consent. Maintain nothing by MPO after midnight or at least 4 hours before the treatment. You take the vital signs and ask the patient to void, okay? No hairpins, no contact lens, no dentures, those are all removed. And then administer pre-medication. Remember, those pre-medication are also relaxant and anesthetic medication to the patient before the procedure. Now let's look at what we do during the procedure. We have intravenous lines inserted in the patient. We monitor BP, pulse, and oxygen saturation level during the procedure. Oxygen is administered to the patient by face mask. A BP cuff is placed around one ankle and inflated to block medication from going to the patient's feet. Okay, an airway or mouth guard is placed to prevent clients from biting their tongue and injuring themselves. Let's look at what we do post-procedure and our nursing intervention. Clients usually wakes up about 15 minutes after the procedure, and when they wake up, they're usually confused. We take their vital signs when the client is awake. The client may be confused, like I said, and disoriented for several hours, so we need to consistently provide them frequent orientation and reassurance. As you're providing to the client too, you're as well talking to the family members that are there to take care of them, so they can relax. Stable vital signs and mental status is satisfactory, and we assess for gag reflux before giving medication. Now let's pause for a second. Why do we assess for gag reflex? We assess for gag reflex to avoid aspiration. Okay, risks for aspiration, because now we're looking if we should also give the client food or medication or water. Okay, what are the potential side effects of ECT? Okay, confusion, disorientation, short-term memory loss. Clients may be confused and disoriented on awakening. Other side effects including headache, hypotension, muscle soreness, nausea, and tachycardia. Memory deficit may occur, but usually they recover completely, at least lasting. They recover their memory at least lasting for 6 months. Take note, remember I said at the beginning of this series that whenever I highlight something is something you should really take note and focus on. Monitor both a depressed client and a client who has recently been prescribed an antidepressant medication closely for signs of suicidal ideas. Okay. If the client presents with increased energy, monitor closely because it could mean that the energy to perform suicide act. Now, if all of a sudden the client is bumped up, has a lot of energy, you should know that this is time to consistently provide one-on-one supervision with the clients because this is when they have energy to execute their plans. All right, guys, we've come to the end of ECT. I hope you've got something, you learned something about ECT, what you need to do pre-procedure, during, and post-procedure. Now let's look at one NCLEX question about this series. A client is admitted to mental health unit with diagnosis of depression. The nurse should develop a plan of care for client that includes which intervention? We've talked about depression today. So can you try out this question and see if you can get the answer? Okay. Encourage quiet reading and writing for the first few days. Identification of physical activities that will provide exercise. No socializing activities until the client asks to participate in MELNU. We'll talk about this. We'll talk about what MELNU is and MELNU therapy. A structured program of activities in which the client can participate. Let's pause for a second. The answer is 4, a structured program of activities which the client can participate. Remember, you're not compelling them, you're not pushing them, because most times if these depressed clients are in their major depressive states, they lack interest in doing anything and they just want to do nothing. Okay, so you structure the activities and encourage them to participate, and it's not something that is competitive, it's something they can do. Okay, a client with depression often is withdrawn while experiencing difficulty concentrating, loss of interest or pleasure, low energy, fatigue, and feeling of worthlessness and poor self-esteem. So, the plan of care need to provide successful experience in stimulating yet structured environments, something that doesn't make them think too much. The remaining options are either too restrictive or offering little or no structure and stimulation. You need structure and you also need to stimulate them. All right, guys, so this brings us to the end of today. We talked about mood disorder, we talked about depression, and we talked about ECT. I hope you learned something from today's series and you got this question right. If you didn't get it right, it means you still need to do more on the reading part. And I encourage you, as you're listening and reading as well, be doing questions. Make sure you're attempting NCLEX questions. Don't let a day pass without at least attempting 10 questions. So your mind is fresh and you learn. And when you're attempting questions, don't forget to read the rationales well. It's not about how many questions you do, it's about how many questions you're able to understand why you got the answer and why you feel the answer. All right, guys. So until next time, thank you so much for stopping by. Thank you for spending your time with us. We'll see you in our next videos. Thank you and bye. Please don't forget to share and like, send to your nursing friends, those are trying to write NCLEX or still those in the nursing school. I think they can learn one or two from this series. Thank you, guys. Thank you so much. Don't forget to like, comment, and subscribe. Tell me what you want us to show on this series. What subjects would you like us to talk about? What systems would you like us to talk about? What would you like us to do? Would love to hear from you. Until next time, guys. Bye. Thank you.